I think this was the introduction that we wanted to make to give you a little bit of information on the logistic and technical issues. And now we are going to give the floor to the first speaker. Christel, you have the floor. Thank you very much, Sandra, for this introduction. Thank you very much and welcome you all. I'm going to introduce the different speakers that are going to participate in this first roundtable, which is around what learnings can we draw from healthcare in maternity wards in Catalonia during the pandemics, reflections from activism and research. We have Josefina Goberna Marta Busquets, and Montse Fernández. And in the first place, I'm going to introduce you Josefina. She is a midwife and she has a PhD in bioethics. She does research on women's health from an ethic and gender perspective. And she now participates in different projects, such as, for example, to give birth in times of pandemics, ethical implications of attention to motherhood and maternity. She's professor of the University of Barcelona, and she participates in the PhD on citizenships and human rights. She participates in the journal Musas, and she's a member of the research center ADUC, Theory, Genders and Sexuality. Josefina, whenever you want, you have the floor. Thank you very much. I'm going to share my screen. In the first place, I want to thank the organization for having invited me to share this time with you and to show you what we have done. And in order to stick to the time, I would like to give you a brief introduction of our research, telling you that, as you know, in Spain, the the possibility of give birth at home was in Spain until the 60s or the 70s. But after that, all women went to hospital to give birth, except for very few cases. For example, in the Netherlands or the UK, where women have continued to give birth in their home. And why was this? So basically, because there was a general understanding by professionals of women that hospital could actually reduce mortality and morbidity related to the fact of giving birth. Why? Because if you saw the TV series called The Midwife, you see that midwives went to the houses in order to help deliver a baby. But then this, of course, was in the first half of the 20th century, but the more complicated labors were in hospitals, and that is why many women preferred to go to a hospital, because they thought that in the previous century, hospitals were places where only ill people went, or terminal ill people went, or the women that gave birth, but then they wanted to give their child in adoption. All this changed because there is an improvement in hygiene with the discoveries of Pasteur and Koch on the microbial theology and the problem of infections that were having place in hospitals at that time. Also improvements in terms of anesthesia, the improvement of surgery, and so on and so forth. This made people see hospitals in a different way. It is no longer a place just for poor people and people that are dying, that do not have a place to stay. Then hospitals become a place to heal certain illnesses that could not be healed at home, and at the same time, deliveries also were better attended in case of difficult childbirth, when there were complications that could not be solved in the houses. At the same time, what happened is that in hospitals, that were like wards. In Barcelona, we have the uh, St. Paul's Hospital, which is an example of an ancient hospital with wards. Then they become hospitals that are more compact in the sense that there is no fear of spreading of infections, and at the same time, you had to take the patients from different places to surgery theaters and X-ray wards and everything. So instead of wards, you had different floors, and maternity floors were also included together with surgery and other specialties. This, of course, meant an improvement of certain situations that could be solved in case of difficult births, but also there is a change in the sense that people start to see delivery as one of the floors in the hospital and just as another part of healthcare. In the 60s, there is this massive change from going to hospitals to deliver a baby. Then, after some 30 years, some people said that this change maybe had some collateral effects that are not so pleasant. In changing childbirth, the report from the UK, they say that there is lack of continuity, long waits, and also lack of information and involvement, and lack of respect and sensitivity when actually dealing with pregnant mothers about to give birth. So in a way, this also arrived in Spain in around 2006 when the report by the ombudsman also gathered to all these complaints on the lack of sensitivity in and respect in the kind of attention given to mothers giving birth in a hospital. And then the Observatory of Women's Health started to also take into account the preferences of women so that there is consensus in the decision taking and that the women can actually have a say in the way they want to give birth. In 2014, the WHO actually issued a declaration, a statement saying that all women have the right to have respectful attention and the right to not suffer discrimination or violence when giving birth. And the report also says that mistreatment or lack of respect during the delivery can be a violation of the fundamental human rights of women. All along this time, we saw the concept of obstetric violence that appeared mainly in Latin America, but especially it started in Venezuela, but at the beginning it seemed that it was something that was exclusive of Latin America, but later on, thanks to observatories of obstetric violence that came out in different countries, it was seen that even the United Nations General Assembly or in the Parliament of the Council of Europe recognized the existence of obstetric violence in the reproductive service, healthcare services. So it seems that since the 90s, there are more and more movements that actually claim for changes in the attention given to mothers that are about to give birth. Then in 2019, with the COVID pandemics, actually made the healthcare system very stretched. And the pandemic showed that the rights of women in terms of sexual and reproductive health were ignored in 4th of May 2020, just after the beginning of the lockdown. So very shortly after the lockdown, then the International Conference of Midwives issued a document calling the health authorities calling the attention of health authorities in with regards to the lack of attention given to women during the pandemic, and also that certain health professionals, such as midwives, were actually very stretched, and the health system actually sort of gave all their attention to COVID patients, and the rest of the services were sort of, I mean, surgery was postponed. But of course, there continue to be mothers delivering children. So this was at the beginning of 2020, and then the statistics office in the United Kingdom said that the prevalence of COVID inside hospitals and is of 10 to 20 times higher with, amongst the health professionals with respect to the rest of the population. So in our research group, we asked the question whether maybe is it possible to continue given antenatal and child delivery attention in hospitals? Are they still safe places? The safety that antibiotics gave us. I mean, are hospitals still safe places? And also, we started to reflect whether measures adopted during the pandemics actually meant more vulnerability for women in different terms. And we ask ourselves these questions because we were working on a research project that had started before the pandemics, that had started in 2019, whose main aim, a very ambitious one, I would say that, of course, we could not attain all our goals because of the problems with pandemics, but the project included philosophers and healthcare workers in order to reflect on concepts such as vulnerability and violence that had been coined by feminist philosophers and see whether they could be applied to the healthcare system, whether these situations of violence or vulnerability can actually be found in hospitals with regards to attention to motherhood. But of course, the COVID pandemics also made all of us vulnerable. And then so the whole paradigm changed. On the one hand, we wanted to carry on research that we had carried out from the healthcare sector regarding obstetric and gender violence, and also research from the philosophic field within this project. But we were not able to do everything because of the COVID pandemic. And then we asked for a grant of the Victor Grifols and Lucas Foundation that together with the grant we had from the Ministry of Education, then we continued a research project in order to analyze the situation that the COVID had caused for mothers about to give birth. Then we interviewed women that had been mothers during the first wave of the pandemics. We also carried out focus groups with different experts, and we interviewed professionals, especially midwives. With regards to the women that we interviewed, they in the first results were the women that we had pre-selected before the pandemic, that is to say, mothers that we thought could be in a situation of vulnerability, adolescent, single mothers, aged mothers, or mothers that had some sort of either obstetric or psychological problems, immigrant mothers, mothers with some sort of disability, those that had needed assisted reproduction techniques. And then we added also women that had to change the place where they wanted to give birth due to COVID, because at least in Catalonia, there were certain hospitals that were closed, and the rooms to give birth were used as COVID attention centers, and women had to give birth in hospitals that were not those of their choice, and also women that wanted to have attention at home, and those that had that before or during delivery were infected with COVID. Given this situation, what happened is that most of the interviews were conducted online. In the case of women that gave birth at home, we conducted the interview in their place. And so it was a bit different because, of course, those that were conducted in person, of course, were longer with some observation. The rest, as said, we did through contacted through the website. Women went to the website, we asked for their consent, and then we interviewed them. And then we interviewed the 13 women. We we were not able to interview young women or other women that would acknowledge having suffered gender violence during pregnancy. And so, of course, this means that maybe we had a biased results, because, of course, those that contacted us online were mainly women that had some level of formal training, so we could not reach all the different profiles that we wanted to reach if the COVID pandemic had not been there. But it was not only, we did not only contact Catalan women, also we contacted women from Asa Catalonia, others that were Spaniard, but that had given birth in other countries, for example, in Germany. So our research also included groups of experts, 7 health professionals, 2 doctors, a gynecologist, and a newborn specialist, 3 midwives, 1 sociologist, and 1 philosopher, and also a couple of lawyers. The researchers had different profiles, sociology, philosophy. We were midwives. With regards to the midwives, we wanted participation of midwives of the primary health care, primary care, and also hospital delivery rooms and third level hospitals, and also midwives that had been transferred from the delivery room to COVID room, because the midwives have to be nurses before being midwives, so maybe they had to work in a COVID room instead of a delivery room. So all we have published up till now is the issue related to midwives. There was a call for papers, and this is the first thing that we analyzed. This is what we were able to publish. And we are now in the process of publishing the results of the research. And also we are now preparing a document with the analysis of the interviews. To give you a general idea, the results that we obtain have to do with vulnerability, because this is the issue that we were investigating from the very beginning. Of course, women's bodies are vulnerable during childbirth, but even more so during the pandemics, because they were deprived, women were deprived of certain rights. And also with regards to professionals, we also saw that they felt vulnerable because there were maybe disputes between different groups of professionals around certain issues, such as the healthcare given to the newborn and women. And in other cases, there has been more agreement. For example, when they told us that in many centers, the supervisors, the nurses and the midwives, they said literally that they felt like crew without a captain. So there have been many difficult situations. So we need to continue working on the concept of vulnerability. And also, from the point of view of the social health crisis due to COVID, we have seen that in the first months there were exceptional measures taken, some of them that clearly breach the rights of women. This changes with time because the protocols change overnight, and healthcare professionals see that they find protocols changing every week, and then the delivery rooms are considered as sort of bubbles, something that are sort of detached from the hospital and work independently. And this, of course, means that there are certain situations of vulnerability because the protection, the PPEs arrive later than in other services, and there's a and there were many measures that some people saw as actually going against common sense, but they had to be applied because they were in the protocol. And also at the same time, many women decided that since they couldn't have the delivery that they wanted in the place they wanted, especially those that wanted to have their baby, to deliver the baby at home, they decided to continue with this idea. And then there are also mobilizations because many women thought that the hospitals were not safe places at that time. They didn't want. Some women decided that yes, they wanted to go to hospital despite the COVID situation, but some women, when it was public to say that certain hospitals actually prohibited the couples to actually go with the woman that is about to give birth, and there are actions resisting this protocol because women did want to have their partners with them. And also, health care professionals tell us that there is a fewer amount of unnatural births, and that very often these women went home too early, even before 24 hours after giving birth, and professionals also said that these women tended not to go back to hospital after childbirth. Of course, the decision taken at that time was not in the hands of women. So if we take into account the autonomy concept of Ocean and Childers and the concept related to the Barcelona Declaration, so this autonomy of the relationships was in line with the situation. And also there was an important issue, which is the possibility of adapting protocols and exceptional measures that were taken in the first months of the pandemic because of a lack of knowledge on the crisis, because no one knew what was going to happen. But in certain cases, these protocols and exceptional measures were just applied without thinking about common sense. Also, from the biological point of view, so the idea of an equal relationship between the user and the professional is also put into question. Another issue that we thought was very important, the safety, the hospital being a safe place or not, this is something that we need to consider. And in the expert group debated on this because, as I said, women in general, some of them wanted to give birth at home, but mainly they still wanted to give birth in the hospital. The professionals that work in hospitals also thought that there was a need to actually reflect on whether hospitals were a safe place to give birth. And it is important to take into account the scientific evidence that we had in the time when protocols actually change every 2 or 3 days. In some cases, this meant a violation of the rights of women. So I've spoken very quickly, says the speaker, but I have given you an idea of the main results that we have obtained from our research. So this is the end of my presentation, and I hope I have stuck to the time. Thank you very much for sticking to the time. Yes, you have. And thank you very much for your reflection on philosophy and the sense of vulnerability. We are now going to give the floor to Marta Busquets Gallego. She has a PhD, a master's degree in gender studies, women and citizenship. She is a lawyer and she's an expert in sexual and reproductive rights in different fields. She is a collaborator of Dona LLum president, which is an Catalan Association for Respectful Delivery, and she she participates in the National Council of Women in Catalonia with the working group on health. She is the author of several publications. I want, amongst which one entitled "Not Everything Has Gone On Positively," where she analyzes the pandemics from the point of view of human rights and gender perspective and social justice. And I am very interested in this book and I want to read it. So she has the floor.
Decir que yo hoy vengo un poco a hablar de nuestra experiencia en relación a este tema desde Dona LLum. Dona LLum es la Asociación Catalana por el Parto Respetado, tiene ya más de una década de trayectoria y seguramente por esta trayectoria pueda hacer una serie de lecturas de cosas que a nosotras nos han llegado, etcétera. Nosotras, una de las primeras cosas que nos planteábamos, ¿no? Es que
one of the things we were thinking about was that we've been activists for decades from a very hostile area to begin with, where they would receive our petitions, and slowly the things that we were asking for have been implemented. And with the pandemic, items that we thought were really real rights, went downhill. And I often state that within the human rights context, when talking about rights, culturally, this is considered as a luxury item, that everything is fine, and when things are not fine, that we will give up on our human rights. But what happens if we don't consider our rights as something that's luxurious, but during uncertain times, we will try and relate to those basic human rights, at least to decide where we're at and where we can decide on. As for pandemic and care given to maternity, in relation also to obstetrics violence, we also think that things that have happened, and because of cutting down on rights and on care during maternity, we have to ask the question, where does the system feel comfortable? And where it does, it's during mediation. And when a time of uncertainty and fear comes, we go to that comfort zone where we feel most comfortable. So what we say is that the system, medical and obstetric system, feels comfortable is where the women have no rights and the users have no rights. We see this. Obviously, there's some debate that relates to the scientific world. And of course, we take a leap forward that goes on to the mental and qualitative context, and we talk about the rights of the users that go beyond the scientist approach. But we were quite astounded that some organizations such as the WHO during the pregnancy and during birth and at the pandemic, at post-pandemic times, will have to face campaigns from healthcare institutions that go against the recommendations, and the recommendations from the WHO might be as crazy as whether a woman had tested positive or not was going to be given care or not. So in the social media, this was censored, and we were then we would then approach the WHO. So what has happened? The other things have happened too. In Catalonia, this is one of the areas where the most mistakes have been made. And we see this as a confrontation to the users during the pandemic. Well, should have been a must in the hospital context. One of the priorities would have been to remove those healthy users from the hospital centers. This happened in countries nearby, in the UK, in the Netherlands, where there were some walled up areas, and they would transfer the healthy women to those specific health centers. This didn't happen in Spain, and neither did it happen in Catalonia. There were more users in those delivery rooms than in other areas. Also, the project for the birth centers was about to be open, and the space for healthy users that were moving around in non-medical setups. So as I said, this project was stopped, and also there was a delay with the deployment of this project. And in fact, not only was it delayed, but when this project is at full speed, the capacity will not exceed 5% of users. So we are facing an insufficient situation. Also, what did the users tell us? They would complain that during delivery, because of fear of infection, the users had to face permanent lesions and damage in their pelvic floor. Also, we were quite angry. We felt, I must say, that there was a romanticification of the means in entities sponsored by telephone companies that had provided tablets to follow up on their babies for those mothers who had, on a prevention basis, had been put separate from their babies, from their newborns. And I'm now going to share the campaign on my screen. I'm not very keen on... Just a second. We can see on the screen that we now see that I'm sharing. What we see is that the women were not informed about their consent with the excuse of the pandemic and the obstetrics violence. They were putting mothers and newborns in separate places. The fact that they were to give birth in total loneliness was also an important point that was mentioned after the lockdown. and the heat of the pandemic, but lots of women were worried about this topic. And there were even strange circumstances that someone could come with you to have a NICO test, a NICOgram, but not during giving birth. And so the system doesn't really feel comfortable with women giving birth by themselves. Obviously, this system is violent because it's not taking into account all these pre-birth system, and the fact that it was even thought of give us the dimension of the situation we have lived. Lots of users have also felt this controversy, this controversial topic. They were very anxious about giving birth with a facial mask on, and this has in turn provoked violence amongst activists. And in both rooms, this wasn't the case, because nobody would even consider that a user would have to give birth and wear a facial mask. And the fact that in Spain this was conceivable, and the fact that they would just said that it wasn't even compulsory, it was compulsory for the healthcare staff and for such hospitals to stop having this, and even after the waves of infection, provided a lot of data of the place that a user has in or within the system. We also feel that this is a matter of transferring the responsibility of care to the users themselves. If the staff, the health workers had the training and were working shifts as they should, most likely we wouldn't be passing on this responsibility to the end users. Also, the fact of not informing properly, because there was a pandemic, the users had to face the fact that no information was provided to them. Very often, there was no clear information provided by the health workers. I have colleagues that would tell me that when arriving at work, everything had changed, everything was new. So no information, there was a pandemic. Who should you ask for such information? Women, when taking into account their rights, were considered as selfish, but there were problems relating to rights. We're now going to see another screen of this association when infringing obstetrics rights at several levels, and this form is also going to be available in different languages, and is also it was an answer, in fact, to several users or many users to send and pass on through to the health ministry. Also important, we've spent many years claiming that there's been too strong abuse of drugs prior and during giving birth, whereas giving such drugs wouldn't be an automatic thing to do in other countries. So out of this complaint and telling the users that they could opt for other things, would get a hostile reaction to them. Because of the pandemic, of course, there was no interest in having that, and so lots of visits, checkups, and that were cancelled, etc. And the answer was, right now you cannot have your checkup, and so that meant it wasn't that important. Because if you've always heard that this is important for the health protocol, and all of a sudden you cannot carry out your ultrasound scan, obviously this will cause anxiety amongst women. And we shouldn't also consider that leaving the hospital should happen too early, too soon after giving birth. And that meant it was a way to getting rid of people, of those women who had given birth. Another topic is privileges and rights. And what happened was that the women had the means, financial means, to get better care. If that was going through the private health sector during the pandemic times, of course, that would mean losses. But if I have money, I'm going to get an ultrasound scan, and I'll go with whomever I want. And as Ms. Goberna said, lots of things happened during the pandemic. And we've had to live through this for a year as an ulterior failure. But this should be as an option for those users if they so wish to have those tests done. What we cannot have is because of getting away from the protocols. They're away in their homes, and they're not. Then basic rights are not being fulfilled with. So we've lived through this as complete failure. There wasn't. The midwives didn't have the capacity also to attend births from home. So we again feel it's unacceptable for those who didn't have the financial means to go to a different scenario where the rights would be complied with and will be dealt with in human terms. And this would need to be guaranteed for all users from within the health system. One of the things that we did from Dona UB was to provide obstetrics violence report during the pandemic times. I wanted to give birth by feeling happy and not angry. This report is available on our website and was written out because out of all the studies that were carried out to all the users, all the forms that we sent to all the users, we started getting testimonies, and we felt sorry because all those comments they made weren't gathered in a common report, and we feel that's important also from the media. And there is one topic that we feel is basic, and it's that going beyond evidence and rights, going beyond all of this, the voices of the users should be enough. And if a woman is explaining to you that this happened to her and she feels it's violent, and one woman after another, it was a good thing, therefore, to think about a report, in spite of all the studies that had been carried out, to express those voices, and hence that report. Basically, I think I was quite fast. I'd rather share and do the social part, not work from the unilateral side. But having said that, I'm there for you if you have any questions or queries. And that's it for me. There are lots of campaigns within the Dona UB association, and we lived that experience by feeling totally vulnerable and not feeling safe. And this does a lot of harm. We felt powerless and helpless. And if we don't go back to the starting point, but rather a much worse point, after the pandemic. And because of the pandemic, of course, these have been difficult times, and it takes a while to recover, obviously, and that at any given time we feel that there's going to be a new excuse produced, and that's why we do this activism work, and how vulnerable these women are. And unfortunately, the piece of news because of the abortion law in the States shows us that everything is very delicate, very fragile, not strong, and tells us that the authorities cannot guarantee and for those rights to be respected. We carry on our contacts with the Catalan Ministry of Health also, and the answer is always the same. We are overworked. We don't have enough time. There were restrictions, and the polls arrived, but then that is to say that the moment is never right. But still, thank you very much, I must say, for having listened to me, and I'm here for you. Thank you very much, Marta. If you don't want to share your screen anymore, you need to deactivate it from where you did it. That's it. Great. So we'll reconvene again during the debate, as you said. Thank you for your intervention and also for fighting for the rights that you do within the Dona Association. And now present Montse Fernández, speaker. She's a sociologist. She's part of the chair of the UNESCO for Women's Development and Culture. She's also part of the University of Big Inclusive Social Means. She's been doing applied research into the social topics and also uses new means in the application or the app of applied sciences. She also works on reproductive and sexual methods in Catalonia, and talks about a very specific group of women, women that tested positive for COVID during their giving birth process. So whenever you're ready. Thank you very much. I want to say hi to all of you, and it's a great pleasure to be sharing this space with you. And from the UNESCO chair, we can bring our little part a little bit and bring forward the study that we've been working on for a year, and that is providing several results as we go. As Josefina pointed out, these or such studies have a dimension and quite a size at the end of the process that will help towards knowledge transfer. In fact, I'm going to be sharing my screen so that we can all see the figures and stats. So, as I said, we are going to be discussing figures and not many, I hope. First of all, I'd like to put this into context. As I said, the project that we've worked on for over a year on sexual and reproductive rights during the pandemic, especially during birth, labor, and postpartum period during the LLum crisis times. This project is quite wide. At the end, it is an exploratory project. It started when there was not much information in regards this regarding women during those times of pandemic during their pregnancy, and we decided to do a quantitative project with indicators that were gathered from an online survey that were distributed in English and in Catalan, and the territory or the sample would be Catalonia. Amongst all the possible cases for birth and postpartum period, we see every single case of women, whether they had been given bad news or not. And this led us to say that there were 500 different variables, a lot of material, a lot of data, but we were lucky enough to be able to enjoy this. And now focusing on the second part of the presentation, the effects of the pandemic during maternity and COVID-19 in Catalonia. We wanted to contrast different experiences of those women who tested positive when they gave birth and those who didn't test positive. So it was at that same moment, in that same space and time. Those who had the COVID-19 during their pregnancy doesn't represent a high percentage, but there are no official data on this reality, but we can say that overall it wasn't a sample, too big a sample for those that did have COVID-19. There weren't that many cases. In statistics, we also take into account small data, not just big data, but specific profiles that can provide a very concise information, whereas that wouldn't be so much the case when working with big data. We can see the slides. We'll see the slides also with more contents, also to see the scope of the project. We have to see the aims. The biggest one was to measure the impact of the pandemic and the healthcare systems management. They didn't talk by themselves. In fact, it was an exploratory research way of leading the project, but they did point at these, the going back of basic rights during pregnancy and during the postpartum period. We also held interviews and we spoke to women who had lived this in their own skin and lived through their pregnancy and postpartum period and the consequences that they had to live through, and that led us to analyze the impact of healthcare systems during the pregnancy and after birth amongst women, and also what strategies and how can women have been able to manage and what changes have they seen amongst the services and the risk of infection for COVID-19. How can one make the two live together, and especially under such extraordinary circumstances such as the pandemic ones. And at least we'll have some information if there is another scenario similar to that. Let's not hope that there's going to be another pandemic. Having said that, the gathering data was done last summer. During July, August, and September, the universe for the survey was women that became pregnant as from 2018. And why 2018? Because we needed a contrast group. Those who became pregnant during the pandemic gave us a lot of information, but we also need information from women who were pregnant before then. And so that enables us to then compare the data. In Catalonia, we have statistics for births with some information with the demographic features of mothers, but that don't take into account several aspects, such as rights, and even less so as anything linked to the COVID-19. So with this questionnaire this was online and through informal ways, channels such as the social media or the media, local media, or linked to the topic, entities, associations. And so the distribution was like a snowball going from one person to another. And in the end, the sample was had 2,600 answers, out of which 2,070 only were valid because some of them may not have been ended or the answers were inconsistent. We had to review all of that, of course. And as from the official statistics from the Department of Statistics of the Catalan government, we know that there are about 35,000 births in Catalonia. And with this sample, we can say that we have a narrow margin of plus minus 2.3% for a 95.5% trustworthy data. Also, what Josefina said, we can say that we had an over-representation of women with highly qualified women, and as for the representation, we didn't have as many women who didn't have qualifications and just had primary or secondary schooling. So we had, in other words, we had to adjust the sample because of this huge gap between highly qualified and not highly qualified women. So with the women who tested positive of COVID-19 when they gave birth or prior to giving birth, just a few days prior to that, this was part of the questionnaire in 87.7% of the cases they had done the test, but 11.9% hadn't taken the test, maybe at different times, but perhaps at the beginning when there weren't as many problems. In any cases, out of these 87.7% where they were tested positive, 84%, 2.54%, sorry, tested positive and 0.2 tested negative or a false negative. So the small data, we are at 2.6% of the total, representing the whole of the group. And now we'll get more into the features or the characteristics of these women before getting into their own experience. The majority are aged between 30 and 39. So it's the 30s. There are mothers for the first time when they tested positive. The majority, 2 out of 3, were considered low risk pregnancies, and the rest had average risk or medium risk pregnancies, and they gave birth at term. This would be the context. For social demographic features, what do we foresee from the risk analysis that we mentioned? It is to talk about 4 axes or dimensions, also in line with the progress that has been occurring in that sense, and the progress that have occurred in the last 2 decades in Spain, but also in Catalonia, linked to the regulations to change or move forward for the sexual and reproductive rights that are more avant-garde. This has happened through the WHO recommendations and of the European Union, and also with bigger participation and decision making of women, and also more integrational or holistic approach and care. And from that, we work to strategies, also to health and sexual and reproductive rights. They've been replicated, they've been put to debate amongst the scientific community that now need to review, especially with those women who tested positive when giving birth.
Regarding these three analysis axes, we must take into account all safety measures related to COVID-19. So the indicators that we have analyzed take into account these four dimensions, and from these we analyzed the comparison between women that had been positive in COVID test and others that haven't, so to see whether there has been differences, to see if they have been treated differently. But what we have seen is that there have been different situations depending on whether the women had been tested positively or not. So the first exercise has to do with the accompanying support, and that has to do with empowerment of women and a series of instruments used during delivery, and also the capacity of actually having these different instruments, and also the information received regarding the positive diagnosis of COVID and the implications that it can have for the baby and for the mother. These indicators, if there are two columns. In the first one, you see the ones with women that had COVID at the time of childbirth, and the other ones that did not have COVID. And here I want to explain that here you do not see the whole of the answers. That is to say that this does not add up to 100% if you actually want to add it up, because there was residual value of some certain women that just don't answer the question. But in order to make things easier, we decided to include these values for the category that actually we are studying. In the case, for example, that obtention of information on the procedure, if there were if the main answer was yes, then you can see it in this percentage, and those that were mainly no, you see the percentage as well in the second block, in the second line. Having said that, in general, with regards to the support or company that allows for empowerment of women, we see that there are many differences depending on whether the women were COVID positive or not, with the exception on the information on vaginal delivery. And here the differences, as you can see, are almost inexistent, but the rest of the cases, there were large differences. With regards to the information on the COVID, of course, this question was only asked to people that had tested positively. And here we see the information in general was not clear for most of the women. Only 1 in 4 say that they received enough information. So we can say that in the first axis, we find already certain gaps that make us see that women that were COVID positive had received less support or accompaniment with regards to the other women. Then the second axis that had to do with human attention and centered and person-centered attention. And here you have these two columns. You have again the difference between the positive and negative COVID cases. We analyzed 4 indicators: percentage of the negative impact of safety measures of COVID with regards to the personalized character of care. That is to say, if you are COVID positive, do you consider that you receive less personalized attention? Okay, also the feeling that the diagnosis actually had an impact on the treatment received by professionals, also the possibility of being accompanied by the person that the mother chose, and this has already been mentioned, because there are certain inputs that actually say that they had not the possibility to choose the support of their partners, and also the possibility to introduce other environmental objects such as music or mirrors or whatever. We see again there are differences between the group that were COVID positive and those that were not, and also the feeling that we say that in the case of women that were positive in the COVID test during delivery, yes, they feel that this affected the care that we received, and also as you can see, 46% said they did have an influence, and also there is an amount of people that do not remember to happen. And this also makes us think, because in certain circumstances, in certain exceptional situations, as it is delivery at emotional level, at physical level, of course, if they do not remember, then it's a pity that they do not remember that time, and that is why there is a high percentage of women that did not know how to answer. So the third axis has to do with the reduction of medicalization, reduction of medication. And here there are different indicators, such as, for example, the inducement to delivery, the possibility to drink liquids, to actually move freely, the number of cesarean than episiotomies, and also the possibility to decide the posture, the posture at the very moment of labor, and also the possibility of having skin contact with the newborn child. So these questions are in line with the results. As you can see here, again, there are two columns, positive COVID, negative COVID, and there was less skin-to-skin contact with the baby, and also maybe there you can see also that there is a high percentage of cesarean delivery and episiotomy in the case of women that were positive in COVID test during childbirth. In any case, as you can see here, there are significant differences also in the possibility of drinking liquids to be induced to the delivery, and there are more studies that have been carried out. And to tell you the truth, there are certain international studies that actually support the result that we obtain. With this, I mean that these are not results specific from Catalonia or from Spain, but other studies in other countries have also drawn the same conclusions. The fourth axis, maybe some people do not like data so much, I'm sorry, but these figures actually allow us to see in a simplified way the whole of the information. Also, because we don't have much time, I thought that it was the best way to give you the information. With regards to safety measures regarding COVID, for example, the need to have a mask during labor, and here we see differences depending on where the delivery to the childbirth took place, whether it was in the delivery room or the surgery room or the emergency room. As we can see here, is that in the place where the mask was being used was in the delivery room itself. In many cases, it was because there was a cesarean delivery, but not in all the cases, and also in the emergency room. I'm sorry, says the speaker, the 100% is in the emergency room, and then in the delivery room we see 96%. With regards to personal protection equipment, with regards to PPE by the healthcare workers, it was mainly used, but in 57% of the cases, this question was only asked to women that had tested positively, and you can see here as well the different percentages regarding whether these took place in the different spaces. You see the percentage also of the 28% of women that say that they do not remember. But in any case, what calls our attention is that the PPE were not used in all the cases. In the case of masks, it was obligatory for most of the women giving birth, but the use of PPE was not present in all healthcare workers. The use of the personal equipment, personal protection equipment, also means that women felt that they had less personalized contact with a healthcare professional. So in this case, the PPE were more a sort of barrier for women rather than they felt it more as the personalization of the contact with a healthcare professional. So if you look at the percentages, you see that it does not add up to 100 because it was a multi-answer questionnaire. So it may be that the same women answered different or ticked different answers. So this would be mainly the general overview of all the indicators where you observe that there are differences between the treatment received by women that had a positive result in the COVID test. Their rights were violated more often, or at least they encountered more difficulties. And having said that, let me just go to some final thoughts that I have written down in the form of questions. And maybe they can be some food for thought for the debate. So what are the questions that we actually would like to ask? How can we use these safety measures, so safety measures so that do not reduce the rights of women during delivery? And this not only during pandemic times. So how can we, in a way, balance safety measures and also to guarantee health safety, but at the same time to guarantee the rights of women during delivery, and especially the right to be accompanied by the couple they choose? Second question, what safety measures have to be applicable when there is no scientific evidence, for example, with respect to the infection from mothers to children, because as we have seen, there has been a reduction in the skin-to-skin contact between the mother and the newborn in the case of women that were positively tested. And also how the space conditions, whole experience, depending on where women give birth, within the delivery room, emergency room, or whatever. So, for example, it is important maybe to think of the possibility of establishing some safe places for women to give birth with all their rights guaranteed. And I think that this is the end of my presentation. I do not know whether I have whether I stuck to the time or not. Well, you've spoken for a bit too long, but never mind, never mind. Now we have about 10 minutes for questions. So if we can see the Wood Club app that Patricia told you at the beginning, to see what are the questions that the participants want to ask. So if you have not written any questions, you can do it now. Or I think that the panelists could also take the floor to ask any questions to the different speakers. I mean, we have 10 minutes for debate, so maybe you want to ask questions to one of the panel, to one of the speakers.
Parece que tenemos pregunta en el chat, Christel.
It seems we have questions in the chat, Christel. Valeria would like to know about legal consequences, especially at the criminal level. Valeria, could you explain a little bit more what you are referring to? Legal consequences of what actions, or maybe some of the speakers have already understood. Maybe you could let Valeria take the floor. Maybe if you allow her to ask the questions, she means whether the obstetric violence is typified in a way. In Spain, there is no specific regulation against obstetric violence. In Catalonia, obstetric violence is included in the laws against gender violence, the laws to protect women from gender violence. Probably you have heard about these laws regarding, for example, menstrual rights and everything, but obstetric violence has not been included in the Spanish law. So regarding legal consequences, there are not many legal consequences, and the expert of the United Nations also mentioned that in Article 161/170. So unless there is a user that, for example, has some damages of the pelvic floor because there was a bad praxis, and she can prove that it was due to this medical bad praxis, for example, that someone has undergone an unnecessary cesarean delivery. This is not illegal if there are certain violent actions, but that do not cause very concrete damages, then there's no legal mechanism that go beyond civil responsibilities. There may be criminal responsibilities, but these would have to be with very, very serious cases. So this is something that is not typified. Yes, and in Spain, this has to do with political responsibilities, and this is something that has not been reflected upon in political, from the political point of view. Thank you, Marta, for your answer, for your very clear answer.
No sé no sé si alguna de las ponentes igual le ha quedado ganas de profundizar en algún aspecto.
Because we still have a few minutes, if one of the speakers, although there are no questions, if you want to clarify something, because there are no questions so far from the public. I would like to add something from the associations. I do think that all these reflections on research data, this is something that should reach the ministries at both regional and also national level, because there are many data that the ministries could use. So it's associations like ours that are actually carrying out work that should be done by the different political departments or ministries, health ministries. It is good for universities to produce all this data knowledge, but it is the administration that should do their task, because this is work that is studies that are being carried out in universities or through associations, and this also has to do with the structural violence that exists. Yes, this is very interesting. We have some questions here to Marta and Josefina with regards to the increase of deliveries at home during the pandemic, and they would like to know what kind of information or public data there exists to this respect. In our case, what we have done is qualitative, so we do not have statistical numbers, but some of the midwives, we know that there was more demand for childbirth at home, and we know that some of the midwives that were interviewed tell us that if certain midwives that had visited or provided healthcare to women in their homes, they stopped doing that in order to avoid transmission of the virus from the midwife to the mothers and children when they went to the homes. So yes, it seems that there is more demand, but at the same time, the possibility of the midwives actually caring for these women that want to give birth at home, well, there was demand, but they were not able to do it. Also, midwives had difficulties to actually travel to give care to women in their homes, and also there also an economic side to this, because giving birth at home is something that you can only do if you can pay for it. And also, very often women did not want to give birth in their own house, but in the houses for delivery. We also had the opposite cases, women that initially wanted to give birth at home, and then together with a midwife, they jointly decided that it would be safer to give birth in a hospital. So there have been different situations. Marta, would you like to add something? I would like to say that ALPA, which is the Association of Midwives in Catalonia, they do have quantitative data, and maybe you can contact them because they do have a data set which is quite interesting. We are at the end of the session, if I'm not mistaken, so maybe there is another question and Montse can give an answer. There's a question on the data of separation of the mother that was suffering COVID and the baby and the newborn. This piece of data was gathered through the open questions of the questionnaire. So women answered some questions, and they gave their testimonies because, yes, there was separation of the mother and the newborn and complete isolation of the mother when it was positive. In other cases, there are mothers that they decided to isolate themselves in a room for a few days. That is to say, the mother, the couple, and the baby decided to actually confine themselves in the same room. Yes, I remember all these situations that were explained by some of the respondents. Now we have reached the end of the first part of the session. We have 5-minute break, and then we come back for the second roundtable in 5 minutes. Thank you very much to all the speakers, all the panelists, and we will reconvene, let's say, at 5:15. Thank you very much.